Okay, we're going to go over hypertension and we're going to go through the drug classes that are listed here one by one. I'm going to go through and explain them, and I'll give you a little bit of information to definitely look at as you're going through these. So remember, the most important thing is the diuretics are the first drug of choice. They have few side effects and they're effective in treating mild and moderate hypertension as well as heart failure, which we'll get into. They work by reducing the blood volume through urinary excretion of water and electrolytes. So as we give them, that's what's going to happen. We're going to excrete the urine, which is going to have the water and electrolytes. And that electrolyte depletion is also really important, which we'll talk about as we go through the different types. Your diuretics for hypertension are categorized as either potassium-sparing, thiazide diuretics, or loop diuretics. So, important thing to look at with that. Obviously, the key in any area for the nurse to monitor is, the risk with the non-potassium sparing is orthostatic hypotension. Anytime we're depleting fluid volume, we want to be worried about that. And then I said the laboratory electrolyte values is also very important, specifically your potassium levels, which you want to be extremely careful on watching in case the patient is going to need a potassium supplement, so they're at risk for hypokalemia. The other thing with the daily weights that you want to watch for is an increase of weight more than 2 pounds in 24 hours, or again a decrease. You want to be looking at the decrease. Are you expecting it or are you not? You're looking at their INO. You're checking for edema. You're also listening to heart and lung sounds to make sure that you have no signs of fluid overload. You also want to make sure that they're safely able to ambulate to the bathroom, as obviously the diuretics are going to increase your urination. The other thing that's important too is patients should know that there's a side effect with them of photosensitivity. And again, they may need to take a potassium supplement while they're on these. So that's really, really, really important. For the potassium sparing diuretics, you want to teach the patient to limit the use of salt substitutes because, again, they have high potassium. Those are all really, really important with this. So I'm going to go back to your thiazide diuretics. So again, we said they're really going to be your first line, and the one that you see most often used is the hydrochlorothiazide. We used to always put HCTZ, and they're actually saying not to do that now because it was getting confused with hydrocortisone, that they're recommending that you actually write out hydrochlorothiazide. So with that, it decreases the reabsorption of sodium, which pulls the water, decreases your blood volume, and then decreases your blood pressure. The onset with the hydrochlorothiazide is about 2 hours. Your peak's about 4, and it lasts for 6 to 12 hours. So generally, you're going to see it given if it needs to be given twice a day, but generally, you're going to see it given once a day. It basically will have a synergistic effect if you give it with other antihypertensive medications, which basically means they're going to work together to improve and further decrease the blood pressure. There's an increased potassium loss if you have these patients on steroids because they're already losing potassium. And the potassium loss also increases the risk for DIG toxicity, so you want to be very, very careful with these patients. Anyone that's on a bile acid sequestrant for cholesterol also will have a decreased absorption if they're on hydrochlorothiazide, so you want to be careful with that. Your potassium-sparing diuretics can be used, but they don't have a lot of diuretic effect. A lot of times you'll see that used in combination with another drug if a patient's at high risk or has hypokalemia, and you'll often see it used with other diuretics at times for patients with hypertension too. Your loop diuretics are going to have the greatest amount of diuresis and the greatest amount of reduction in blood pressure, but they're not recommended for maintenance therapy for hypertension because of the significant side effects. Again, you worry about the hypokalemia, the dehydration, and also ototoxicity, which can lead to deafness in patients. So you want to be very, very careful. Your drugs that affect the renin-angiotensin-aldosterone system are another set of drugs that you're going to see used. So in this area, so I'm getting all my notes here together. Your ACE inhibitors and your angio2 receptor blockers are what you're going to see in this category. So the medications are going to treat high blood pressure by interacting with the renin-angiotensin-aldosterone system, which they call the RAS system. They're going to lower peripheral resistance, and they're going to decrease blood volume, which is going to thereby lower your blood pressure. With your ACE inhibitors, the drug you often hear referred to as your enalapril, which is Vasotec. The mechanism of action is to decrease the blood pressure by reducing the angiotensin II and aldosterone levels and produce a significant reduction in their blood pressure. So the enalapril may be used alone or in combination with other antihypertensives, including sometimes your diuretics. The primary use obviously is for hypertension, and they have few cardiac side effects. So with the enalapril, you can see hyperkalemia as a side effect. There can also be a rapid fall in blood pressure, so you want to monitor the patients closely and let them know they can have headache, dizziness. The big side effects to look out for that are rare but are potential side effects are the angioedema, neutropenia, and agranulocytosis. You're going to want to be looking at that white count as well. So again, the angiotensin converting enzyme inhibitors, or your ACE inhibitors, are going to block the angiotensin 1 from converting to angiotensin 2, and they're going to decrease the peripheral vascular resistance and thereby decreasing the blood volume and blood pressure. The other side effect that's really important to mention with this is the persistent cough, and that's one of the most common reasons that people stop taking the ACE inhibitors is because of that dry, nagging, annoying cough. Excuse me. Your angiotensin receptor blockers, or your ARBs, they're basically going to block the action of the angiotensin 2 after it is formed. It's very similar to the ACE inhibitors, but they've been found to have fewer side effects. So again, basically they're going to have the same action, but they're going to have less side effects, and they're going to be blocking angiotensin 2 after it's formed. You have your calcium channel blockers, which basically these drugs exert beneficial effects on the heart and blood vessels by blocking calcium ion channels and limiting muscle contraction, relaxing arterial smooth muscle, and then lowering the peripheral resistance. Basically, they're going to work either by selectively affecting blood vessels or by affecting both the blood vessel and the heart, and we'll talk about that more in a couple of minutes. The calcium channel blockers are usually used alone for chronic hypertension. They are, however, they're not used alone. I'm sorry. You got me wrong there. They are used alone or in monotherapy with elderly and African American patients. A lot of African American patients are found to not be treated very effectively with other antihypertensives, so they do tend to react better to the calcium channel blockers. For the most part, they are not used alone for chronic hypertension. They're used in conjunction with other medications. I apologize. Basically, the key areas for a nurse to assess when they're administering these is the ECG rhythm, their heart rate, their blood pressure prior to therapy, during therapy, periodically throughout therapy. They also want to monitor, obviously, the heart rate and the blood pressure regularly. They want to look at the health history, specifically for heart dysrhythmias, because the drugs are often contraindicated in anyone with a dysrhythmia. Assessing for signs of heart failure and reflex tachycardia, because calcium channel blockers can reduce the myocardial contractility. The other thing is, if it's given IV, tachycardia and hypotension can be more pronounced. So it's really important that they are assessed for these things. So again, originally calcium channel blockers were used for angina because they're found to lower the blood pressure as a side effect. They've been now introduced as antihypertensives. I mentioned already that they're more helpful with elderly and African American patients, specifically African American patients, because they are often not treated well with the other medications. Calcium channel blockers have been found to be very effective with these patients. So how they work, again, they limit the calcium from entering the cell and limit the muscle contraction. Low doses are going to relax the arterial smooth muscle, lower peripheral vascular resistance, and then decrease your blood pressure. Like drugs such as nifedipine are selective for the calcium channels in arterioles, whereas something like verapamil is going to affect both the cardiac muscle and the arterioles. So remember, I mentioned to you, you want to be very, very careful and make sure that you are assessing the patient for cardiac dysrhythmias, because these drugs can affect the dysrhythmias or end up worsening the dysrhythmias. Our next category is our adrenergic antagonist. So with our adrenergic antagonists, the thing that we want to make sure that we are paying close attention to excuse me, sorry, is the beta blockers and the alphas. But the beta blockers are going to be your big category that you're using. They're going to decrease the beta blockers. They're going to decrease the heart rate and contractility. They're going to reduce your cardiac output, and they're going to lower the systemic blood pressure as a result. Remember, your beta 1 is your cardioselective receptor when we're talking about the sympathetic nervous system. So if the drug is not cardioselective, it is not only going to work on the heart, it's going to work on other systems. So it's really important that you're looking at whether the drug is cardioselective or not. Remember, if it's not cardioselective and it's going to affect the lungs, we do not want to give a drug, a beta blocker, that's not cardioselective to a patient with a history of COPD or asthma, because it's going to lead to bronchial constriction, and obviously it's going to cause significant issues with your patient with COPD or asthma. So what's important with these is that they're going to reduce the cardiac workload, so it's going to ease angina symptoms and slow conduction through the myocardium, so they're often given for dysrhythmias as well. Adverse effects of this, remember that they inhibit your fight or flight. They're going to be blocking that sympathetic response, so you're going to see that the patients are often going to have a slowed heart rate and contractility. They're going to be fatigued, they're going to be drowsy. So remember, it's the opposite of our sympathetic, where it's still part of our adrenergic system, but we're blocking that sympathetic response. So it's a beta blocker or an adrenergic blocker, and we're going to see the opposite of fight or flight. With the alpha-1 adrenergic blockers, again, they're going to block the sympathetic receptors in the arterioles, causing vessels to dilate. They're less effective in long-term trials. Sometimes they're used with a diuretic if they are used, so you would see it in a combination drug such as Cardura. Side effects with this are going to be your orthostatic hypotension, your dizziness, your nauseousness, your nervousness, and fatigue. So a lot of side effects for these drugs. Just looking to see if I have anything else I wanted to make sure I'm mentioning. So again, they're often used in conjunction with a diuretic if they are used, your alpha adrenergic blockers. Your alpha-2 adrenergic antagonists are going to decrease the outflow of the nerve impulses from the CNS to the heart and arterioles. They're going to slow the rate of conduction, velocity, and dilation to your arterioles. Remember, the primary receptors are located on the presynaptic nerve endings, and when they're activated, they cause a decreased production of what's called CAMP. Basically, what they're going to do is they're going to inhibit the norepinephrine and decrease the norepinephrine in circulation, which is thereby going to decrease your blood pressure. So basically, they're going to inhibit the norepinephrine, which is then going to decrease your blood pressure. The big issue with this is there's a lot of sedation and CNS effects, so they're really not prescribed very often. We're not going to get too much into that because they aren't really that big of a, not that highly prescribed. Your direct vasodilators are going to be the drugs that will cause direct relaxation of vascular smooth muscle. Significant side effects occur with these drugs, so it's really important that you pay attention to those. Drugs that you're going to see in this category are going to be your hydralazine and your nitroprusside. The side effects are going to be those such as orthostatic hypotension, fluid retention, headache, and sometimes palpitations. With the hydralazine, there's the potential of a lupus-like reaction, a severe hypotension, and myocardial infarction and dysrhythmias, as well as shock, are all potential side effects for the direct vasodilators. So they're going to be used extremely, extremely, extremely cautiously. The other thing is use of these can lead to the reflex tachycardia. So you, again, want to be really careful with these. You could potentially see a diuretic used, but you have to be extremely, extremely, extremely cautious because, again, if you use diuretic in conjunction, you're going to significantly decrease their blood pressure. The nitroprusside, many of you who work in emergency or ER type setting, emergency or ICU settings, have likely seen this use. It can be, it is a drug of choice for hypertensive emergencies, partially because the half-life is so short and it can be easily titrated. The thing with it is it's very, very toxic, so you want to be really careful and you don't want them on it longer than they have to be. There's other drugs that have rapid onset if given orally. Those would be clonidine, captopril, furosemide, labetalol. So these are your hypertensive drugs. I hope this helps, and we will be on to the next.